Welcome to this session in our year-long program on global health and medical ethics, sponsored by the Global Health Initiative and the McLean Center for Medical Clinical Ethics. My name is Shola Olopade, and I'm the Clinical Director for the Global Health Initiative. It's a great pleasure to introduce speaker today, Jean-Luc Benoit, who is well known to most of us here. He's an associate professor in the Division of Infectious Disease and Global Health. He graduated from the University of Louvain, did I call it right, in Belgium with a diploma in tropical medicine a while ago, and did his residency training at the Metropolitan Hospital Medical Center in New York, again, a few decades ago. This was followed by an infectious disease fellowship in the combined University of Illinois and University of Chicago fellowship program, before coming to the faculty here at the University of Chicago. He's the co-founder of the University of Chicago Infectious Disease Fellowship Program, and he's been the program director since then. This was in 2004, I believe. He has a long-standing interest in tropical medicine and diseases in travelers, and he established the University of Chicago Travel Clinic. Some of us have been regular visitors because of the global travel that we've had to undertake. He's clearly an expert in travel medicine, and also is an active, has serious activity in HIV and infectious disease management. He plays a prominent role in the organization of the teaching curriculum in infectious disease fellowship, and also teaches parasitology and tropical medicine extensively within the medical school and through the infectious disease fellowship program. His research interest includes studying how viewpoints of patients infected with the HIV virus influence their adherence to antiretroviral therapy. Today's presentation is a very timely subject, swine flu and the next influenza pandemic. I'm sure we're in for a very excellent presentation, so join me in welcoming Benoit, and we listen to your presentation.
Thank you very much. So the talk is swine flu and the next influenza pandemic, but of course we have the next influenza pandemic now, so it makes it a little timely. Also, though, we should worry about the next pandemic, and so it's still an accurate title. So influenza A is really what we're talking about when we talk about influenza pandemics. You know, there's influenza A, B, and C that cause influenza virus infection in human beings, but only A and B result in significant morbidity and mortality during seasonal influenza. However, only influenza A causes the pandemics that cause so many million deaths in the world. And so that's really what we are interested in today. We should know that influenza A infects humans, but also birds and swine, as well as another couple of animals that are not important in the epidemiology. But all three, humans, birds, and swine, are important to the epidemiology of pandemics and influenza in general. The reservoir of influenza is asymptomatically infected waterfowl that has an enteric infection and does not get sick from the disease. And that includes ducks and geese and migratory birds that are therefore involved in the epidemiology of pandemics as well. So this is a good schematic representation of influenza A. And what we should know first is that there are 8 segments in the genome. Each one of them can mix up with other influenza virus when the same cell is infected by 2 viruses. And so that's going to be very important when we talk about reassortment of the virus. Important also are the surface glycoprotein, the hemagglutinin and the neuraminidase, as well as a little bit the M2 protein, because they have so much importance in how we follow these infections. So we have two surface glycoprotein, hemagglutinin and neuraminidase, that are going to help us classify influenza A. Influenza A are really classified based on serotype of hemagglutinin and serotypes of neuraminidase. And for example, the influenza we're going to talk about include H1N1, H3N2, and H5N1. And there are 9 serotypes of neuraminidase in human beings as well as in avian infection with influenza. But it's different for hemagglutinin. Hemagglutinin, we have 16, so many more in avian influenza. But humans only have gotten infected, we know, with 6 of them. Only 3 of them, H1N2 and H3, are involved in pandemics. So we go from a reservoir of a lot of genes here to a much more limited number of viruses that are going to infect us. Currently, in the circulation, we have seasonal and pandemic flu, and those are only H1 and H3 serotypes. So you know we have the seasonal H1N1, the pandemic H1N1, the one we are going to talk about or more, and the seasonal H3N2. All 3 of them can kill people this year in the United States. Hemagglutinin is important in terms of the receptor tropism of influenza, and that's important to understand. When they talk about new types of influenza infections in humans, it's important that we understand this. The first thing is that the hemagglutinin binds on a receptor that includes sialic acid linked in an alpha-2,6 linkage in human beings, mostly. It's not 100% true, but mostly it's like that. And on the other hand, in avian infection, it's a different structure, alpha-2,3 linkage. And the two are not interchangeable, meaning if a virus is mainly able to bind to the alpha-2,6, it will not bind to the alpha-2,3 and vice versa. And so that explains the receptor tropism of influenza A. Now that is due, in fact, to a specific amino acid change in a certain position 226 of the hemagglutinin. So for example, if you have a leucine amino acid in that position, the hemagglutinin binds to the human strain, the alpha-2,6 sialic acid. But if you just have one substitution, it's glutamine instead, it will bind to the avian receptor. And the pigs behave in a very interesting way. They have both receptors readily available for influenza A. And so pigs get infected by human virus and by avian virus, and they can mix the infection in the same cell and reassort those genes that I talked about, the 8 genes of influenza A. And so they are a really important group, and although there are also quails that can do that, pigs are more important because people and pigs tend to be very close in many cultures, especially in Asia, because of food and because of location of the animals and the people. There is much more opportunity to infect each other.
Did you say quail was the other one?
Yes, but it's minor in the epidemiology. Feel free, by the way, interrupt me anytime, because I think it's better than keeping all the questions at the end for this talk. All right, so this shows you in a schematic way how hemagglutinin binds first to the sialic acid, and then there is endocytosis of the virus. And then in the endosomes, you have also a role of hemagglutinin for the fusion of the membranes. And so hemagglutinin is going to be very important in terms of what happens to the virus and whether it becomes a pandemic or not. It's also important, by the way, in terms of whether we have protective antibody to this virus. So if we have good neutralizing antibody to hemagglutinin, we're not going to get severe flu. At the same time, if there is a new hemagglutinin that we have no immunity to, it's going to be a major issue for our immune system. Influenza M2, I told you, was also somewhat important. It's called the M2 ion channel. It allows H+ to enter the cell and then releases the virus content into the cell. The importance of this is that we have drugs that are M2 channel blockers, the good old anti-influenza A drugs, amantadine and rimantadine. Now, this only worked for influenza A, by the way, not B. And unfortunately, we are losing these drugs because a lot of these viruses we're going to talk about have resistance to these two drugs. Well, I'll talk about that at the end. The life cycle is, of course, well known, and I won't go into that. But at the end of the life cycle, you have the second major service protein, neuraminidase, that plays a role in the budding and the release of the virus from the cell. And neuraminidase is also going to be important in terms of how to prevent influenza infections, in terms of immunity, in terms of vaccine, and in terms of changes in the cell types. So the neuraminidase plays a role in the end of the cycle, but we also have very effective drugs that are neuraminidase inhibitors. We have 3 of them. 2 are actually approved. One is investigational but available on the specific protocol. There is no advantage in using one over the other in terms of efficacy. It's more the route of admission that's different. So administration PO is Tamiflu or oseltamivir, easy to take if you can take PO. But if you're an ICU patient and you're not sure that the ICU patient can absorb anything PO, you might want to use the IV peramivir, which is now available. We have done that in this ICU this year. Zanamivir is as effective, but it has to be inhaled, and that makes it much less usable in practice. So we use much more Tamiflu than Relenza practically. So the first thing we should remember, though, is that seasonal flu is a big deal, right? Seasonal flu, everybody gets the flu. I don't want to get the flu vaccine. I'm going to get sick from it. But people always forget little details about seasonal flu every year. We know, being physicians, that it kills a lot of patients. But what about in the population at large, people who are not admitted? A study recently published in the American Journal of Epidemiology in 2006 estimated that before the pandemic flu we're dealing with, between 1979 and 2001, the attributable mortality of influenza was about 40,000 in the US. There is a broad confidence interval, and you have to realize that this is not completely settled science. There are different publications that have a little bit different numbers, but we're talking about significant numbers. This is not the number of reported deaths. The number of reported deaths from influenza is going to be less. And so when we compare this number to the number I'll talk about when I talk about pandemics, those numbers are not fully comparable because we're going to talk about the actual estimation of the number of deaths being much less scientific usually in pandemics. The CDC, and again, they look at data in a certain way, and it's not all 100% accurate, most likely, but estimate that about 5 to 20% of the population get infected every year with influenza. Greater than 200,000 admissions. You'll see numbers as high as 400, so you'll see variation in the numbers. But they say about 36,000 deaths. That's a number you see quoted actually a lot. Understand me, this is an average, and some years are worse than others, and we all have experienced that. Now, before 2009, we were dealing with seasonal influenza H1N1 and seasonal influenza H3N2. Okay, the H1N1 we're dealing now, the pandemic flu, is different from the seasonal H1N1. So people die from the flu and seasonal flu, but when we look at who dies from the flu, we find that there is a U curve in which, of course, patients who are older than 65 have a much higher risk of death. A lot of them have underlying diseases, but also just being older puts them at higher risk of death. Young people have an increased risk of death, but you have to realize that They also have a markedly greater increase in the admission, but not as much an increase in death as older patients have. So older patients get a lot of admissions, a lot of death. Kids get a lot of infections. They get a significant increase in the number of admissions, but not so many deaths, okay? But they do have an increase in death compared to people in the middle. So it's not good to be a little kid, and it's definitely not good to be older than 65 with the seasonal flu. In here, though, we also have death, and we have death overwhelmingly among patients who are not healthy but have some kind of underlying conditions. So how is influenza transmitted? You'll find good science to say it's transmitted through respiratory droplets. So when I talk to you, I can send droplets of saliva up to 6 feet, so we're about fine. But also, of course, if you cough and sneeze, okay, those would be good ways to transmit influenza. It's probably the majority of the cases are transmitted that way. Now, direct contact with secretions also can allow transmission. So let's say you examine a patient, and then you put your fingers in your eyes, you can get influenza that way. Okay, so it's not difficult to get influenza if you examine a patient with influenza. Now, what is not here is aerosol transmission. So you do not have documented aerosol transmission of influenza. But if you look at the CDC website, they say maybe when you're close to the patient, there may be aerosol transmission. Aerosol is what transmits tuberculosis or chickenpox. That's why we put those patients in pressure-negative rooms so we don't have infection in the whole ward through the ventilation system. Influenza definitely doesn't get transmitted that way. So not aerosols over long distance. You won't have this problem. But is it possible to have aerosols in close contact with a patient? Maybe. I think it's not proven, and I don't think it's actually accurate. But you can't completely rule it out. Now, we have abundant receptors for influenza in our upper airways, and most of what's going to happen is biting of influenza in our upper airways. And then it can spread from upper to lower airways if you do badly with influenza. Incubation is short, average of 2 days, so transmission occurs. Disease occurs, more transmission, so it can spread very quickly because of that. And although usually we say that an adult would be infectious from the day before symptoms for about 5 days after illness, this is not true necessarily in children. They can be infectious for 10 days or more, and it's definitely not true in our immunocompromised patients. For example, bone marrow transplants have had shedding of influenza for a month or more. And so those are quite different in terms of the risk of transmitting influenza to other patients and healthcare workers in the hospital. So this also tells you that healthcare workers are at significant risk dealing with patients with influenza, and that they will also risk infecting patients. And so that's a good reason to ask all healthcare workers who take care of patients to be immunized against influenza. So you know already the high-risk condition for seasonal influenza mortality is cardiovascular pulmonary condition and a chronic metabolic disease like diabetes, renal dysfunction, hemoglobinopathies, HIV, and any immunosuppressed patient, neurologic conditions that will prevent clearance of respiratory secretions. And important is nursing home residents. Many of them, of course, are in the nursing home because of their comorbid conditions. Mortality is estimated to be 2.8% a year. So we are really talking about a common way to die in a nursing home. Now, there are other considerations. People who are healthy but are pregnant, especially second and third trimester of pregnancy, have much higher risk of death. And young children have especially high rates of morbidity and being admitted to the hospital. Complications, as you all know, otitis media and pneumonia are major complications in kids. But death, fortunately, is not as common in that population. In proportion, it's small, but there are every year more than 100 deaths from influenza in kids. Yes, sir?
Is there any explanation or theory about why it is the pregnant women are so susceptible?
So pregnant women are susceptible to a number of infections because of the tolerance of the fetus. So there is an immune suppression associated with tolerating the fetus. And so that actually gets worse with the age of pregnancy. And so it's worse in late pregnancy. A common example is chickenpox. If you get chickenpox in pregnancy, it is a high risk not just of congenital infection, it's a high risk for the mother. And we have had a few deaths of chickenpox in pregnant women here at the University of Chicago in the 18 years I've been here. So, and there are other diseases that behave like that. So it's part of being pregnant and having that immune tolerance for the fetus that puts you at this increased risk. So, and of course, children, it has to do with also the maturity of the immune responses, how many times they've been exposed to influenza, etc. So. Elderly patients, I mean, I hate saying older than 65 is elderly nowadays because we have so many very active people. My dad is 84 and still working, so we should not call them elderly anymore. But older than 65, and usually they do have underlying conditions. So most people who die from influenza die from pulmonary complications. It's possible to have myocarditis and encephalitis, so there are other ways you can die. But usually we're talking about mostly death from pulmonary complications and sepsis. And there are two major ways of dying from seasonal flu, which is primary influenza pneumonia. And that's often in the setting of having cardiovascular disease, for example, being young or pregnant. And you have relentless progression from the onset of influenza. You have bilateral infiltrates, but they don't look like consolidation, not like bacterial pneumonia necessarily, and high mortality. The other way is having a secondary bacterial infection, and of course we are very well aware of that. Patients who have the flu get better and then get worse and get admitted to the hospital, and it looks all like a bacterial pneumonia. Often it's actually strep pneumo, sometimes it's staphylococcus, including community-acquired staphylococcus aureus. And so these two we definitely have to think about. Sometimes it's also just H flu. That, if we treat aggressively, has a lower mortality. Of course, we're talking about rich countries where ICU care is available and we have early use of antibiotics. Okay? So that mortality might be much greater in the area where you don't have quick access to healthcare and antibiotics. So we have the seasonal influenza vaccine, which is, remember, influenza B also kills people every year. So it has an influenza B in it. And then it has two influenza A that are seasonal. So one is H1N1 and the other one is H3N2. Lately, H3N2 has killed more people than H1N1, okay, before the pandemic influenza. But before, H1N1 used to kill more people. And so these things change over time as the immunity of the population improves to some viruses and others come into play. We have two vaccines that we use for seasonal flu. The injectable is inactivated, meaning killed. So when your patients say, I get the flu from the vaccine, they can't. It's approved after 6 months of age, and you can give it to everybody who should get a flu immunization, except for a couple of contraindications. The nasal spray live attenuated influenza vaccine, though, is for healthy people between 2 and 49 years of age. Okay, so no, not in older than 50, not in younger than 2, and not in people who are not healthy. And even if they take care of an immunosuppressed patient in their house, and us in some way, we do take care of immunosuppressed patients, there is a concern that maybe there is a risk of transmission. That concern is questionable. The seasonal flu vaccine does not provide any protection against our pandemic flu. Okay? So even though it's also H1N1, it has no cross immunity to it. So it doesn't do anything to it. Now, there are people who should not get the flu shot. People have allergy to eggs because we do grow the flu virus on eggs. People who had a prior severe reaction to influenza. What about Guillain-Barré syndrome? Guillain-Barré syndrome has been associated with flu vaccine and flu infection, okay, so both. But only if the patient had developed GBS within 6 weeks of the prior influenza vaccine would you consider that a contraindication. So that's going to be very few patients. Also, the risk of getting GBS with the vaccine is extremely small, all right? About 1/1,000,000 with our vaccine currently. We don't immunize children below age 6 months. And of course, if you have an illness, should you or should you not immunize a patient? Well, if they have a fever, you probably should not immunize them that day. Regardless, even if it doesn't make them worse, if they get worse, they'll say it's because of the flu shot. Okay, so we don't do that. But if they have a little cold, sure, immunize them anyway. Just tell them, remind them it's a killed vaccine, cannot make their cold worse, and then they won't think that if they got worse, it was from the flu shot. Any questions so far? So that's the introduction to what we're going to talk about now, which is the genetics of influenza a little bit. So the first thing that happens to influenza is a progressive evolution, or if you want accelerated evolution, a little bit like HIV as accelerated evolution. This virus changes all the time. And that's called antigenic drift because it's a progressive change due to mutations. And the reason that there are so many mutations is because the influenza RNA polymerase has a high error rate, and then after that has occurred, there is no proofreading at all. And so we have a messy enzyme, exactly the same as in HIV with the reverse transcriptase. And so that introduces more rapidly changes in or mutations in the genome of the virus. So those occur all the time, mostly though in those two major glycoprotein, hemagglutinin and neuraminidase. And of course, that means that in the population, if you don't get immunized, you're going to have antibody from the prior exposure to prior flu seasons. But remember, you don't get it necessarily every year, so you got exposed a number of times. And it no longer neutralizes fully the new virus, and so you're going to get a little sicker. You're going to get the flu, and you're going to get a little sicker because your immune responses are not as effective. But also, the virus that's more different is going to be transmitted more. And so you have this immunologic selection of the new virus. And so the virus that was well inhibited by the immune system disappears from the population, and you have that new drifted virus that becomes a more prevalent one. And so that's the balance of the changes in the virus and the escape from the immune system that makes the population of a human influenza virus change all the time. Now, if we immunize people every year, though, first you get this exposure every year, and we change the vaccine the best we can to the latest possible virus. If we're too late, though, we're not going to get the best vaccine that year. And we try to get the best vaccine possible, but it's not always going to be the best vaccine. So some years you'll have a vaccine that's a little less effective than others, but the vaccine is always effective in part. The other thing that happens is that if you get yearly immunizations, over time you build a more, a broader, if you want, reactive immunity to influenza. And so as you see a population over time, the immunity to influenza that's been circulating for a few years is going to improve every year through infection and through immunizations. Now, pandemics are quite different. So pandemics is really due to a major change in the virus. So that's nothing to do with that drift. You cannot have a drift that results in pandemic. What happens, though, and this is 1918-19, the Spanish flu. This is 1957-58, which is the Asian flu. And then the Hong Kong flu in 68-70. And those are the three pandemics we had in the 20th century. Now, we know there were pandemics before because we can look at antibody and serologies, but that's not the same level of evidence than actually having isolated these viruses. Interestingly, we have actually the isolate of the Spanish flu, okay? So that's been recovered from autopsy tissues, and so we have the whole sequence of the Spanish flu. So what we can see here is the Spanish flu was H1N1 and circulated until 1957. Then it went away. H2N2 appeared That was the Asian flu. They went away in about 11 years. Then we got H3N2, which is still here. H3N2 was the Hong Kong flu. And then interestingly, H1N1 reappeared in 1977. And interestingly, too, it was very similar to that virus. And it appeared that it came from Russia. And so the theory is that it was being studied in some way, and it got into the general population and caused a recirculation of the virus. But because the population still had, I guess, as a whole, enough immune responses, it didn't cause a pandemic. So, but it's not reassuring for what people do with the flu now that we have the Spanish flu available again. It's not completely reassuring for that, what the military, for example, could do with these viruses. So this is a good slide because it shows us how things change, and every time we have a pandemic, it's a change in the hemagglutinin or hemagglutinin and neuraminidase. So that's called an antigenic shift when you have a change like that. And so you have major genetic differences between them because you basically have a new segment of the genome. You have those 8 segments, and you have at least one new one. So you have a lot of new genes in that virus. And so that means that you have a novel H or NA serotype to which most of the population has absolutely no antibody and cellular immunity. And so there is no immunity to that virus in most of the population. So what's really typical of a pandemic influenza is that you have a high susceptibility in the population. And then that virus also has to be transmissible easily, otherwise you'll not ever have a pandemic. If you have a virus that's very lethal and very different, but is not transmitted from person to person, you will not get a pandemic. So you need both susceptibility and high transmissibility of the virus, and that can cause pandemic influenza. So pandemic influenza doesn't necessarily mean the virus has to be very deadly, okay? It's just something different. It's easy to transmit, and it gets transmitted from country to country. In the end, it covers the whole world. That's a pandemic influenza. So one way antigenic shift may occur is because of reassortment. So one of the 8 genome segments of influenza that was circulating in the human population changes, and you have all of a sudden 1 out of 8 at least new segments in the genome. So for example, let's look at the Asian flu. We'll talk about the Spanish flu later. But the Asian flu of 1957, what happened is that we had the new influenza A, H2N2, that originated in southern China and caused a 2-wave pandemic. It killed, and those are, the numbers that are not extrapolated. They are numbers that are estimated directly to be due to this virus. And it's greater than 1.5 million people who got killed. Truly, the real number may be a little higher than that because we don't always count all the deaths due to the flu as death from the flu. In the US, it's estimated there were 80,000 deaths. Yes?
The pandemic is in all the continents, right? They say that
yes.
The only in America, South, Central, and North America, it will not be pandemic. It has to be...
well, pandemic is always going to go all over. So if it's all over America, it will go to the others. But pandemic just means there is sustained transmission between people, and it's also in a number of countries. It doesn't necessarily have to be different continents, but it will always be different continents. Yeah, it's not. So you can declare a pandemic before it goes to another continent.
So what do you find pandemic?
So pandemic means there was sustained transmission of influenza. This is the definition of influenza. You're right about the pandemic definition in general, but in influenza we don't wait for it to be in 2 continents to call it a pandemic. In other words, if it's in most countries in the Americas, it's going to be a pandemic regardless if you have sustained cases in human population in multiple countries. That's a pandemic. So it doesn't require different continents. However, with flu, you'll always have. It's always going to go to different continents. So that's why they call it pandemic before it's a pandemic, if you want, because it's going to happen if you have that situation.
And the reason of my question is because when when this started to happen, there was a lot of, media, pandemic, we're all dying. So they use the word pandemic, and we don't necessarily understand the definition.
Right. Pandemic is scary, yeah.
That's what I was asking
right.
you guys to clarify.
And so pandemic has nothing to do with the severity of the influenza. Yeah. It is more transmissibility of influenza, how contagious it is, and how we expect it to, in the end, cover the global population. And of course, it's, you have a WHO definition, but people don't always follow the WHO definition. But WHO is the one that calls the pandemic a pandemic. So it has to have an organism that decides when it's a pandemic. The importance of declaring a pandemic is not to say everybody's going to die, but it's to say we have to invest a huge amount of public health resources into this outbreak of influenza. So it's very costly to declare a pandemic. But it may have major benefits if we, for example, get vaccines quicker, if we can get better infection control and these kind of things. Hand washing is a very good way to prevent the flu. And so declaring it a pandemic allowed many people in many countries to say, now people have to wash their hands. Like we did here. If you entered the UFC buildings, you had a little station where you could wash your hands, and strong encouragement to wash your hands. And it's because it works well. So the other thing about this pandemic is that other than killing a lot of people, so at least 80,000 in the US, it had, so it was a reassortment virus with human and avian genes. And it had a gene that's called a PB1 of avian virus origin that is a mean one to have. The greatest mortality, though, was in the very young and the older than 65, the U curve, like in the normal flu, seasonal flu curve. And the case fatality was not that huge. It was 1 in 1,000, okay? So when we talk about pandemics, we're not necessarily talking about very high mortality. 1 in 1,000 is high, but it's not the same as we'll talk about the Spanish flu. The vaccine was available too late to change anything to the pandemic. Okay, so that's the good old way to prepare a flu vaccine, and it's not changed. We have to grow it in eggs, and it takes forever. And so a pandemic can go through the globe before you have a vaccine available that you can distribute to most people. And so even when the vaccine is available, you still have to immunize people, and it came too late in this case. And this virus persisted until the late 60s, as we saw, and then went away. Another reassortment occurred in 68 with the Hong Kong flu. It originated in Hong Kong and replaced the H2N2 and had a 2-year pandemic, so 2 waves, if you want, 1 year apart, and killed at least 1 million people and 34,000 in the US. If you look at 34,000 here, and I told you seasonal flu kills about that number every year, these are not the same numbers. These are very underreported numbers. Okay, so these are, if you want, the confirmed cases, the one that we know for sure were due to influenza. But there is an indirect mortality associated with influenza that is greater than that. All right, so again, we had genes from an avian virus, and H3 persisted as a seasonal flu. So little by little, it was a very bad disease, and then it became just a regular seasonal flu. It has persisted. The virus is changing as a drifting virus, but it's not that different from what it was. But our immune system as a population has improved, and so we do not have a pandemic every year. We have an initial pandemic and then seasonal flu. So both of these Asian flu and Hong Kong flu pandemics were the result of reassortment virus. Okay, everybody is clear with that? So that was just getting genes from different viruses that were from avian and human virus. So this shows you that. So this is actually a partial, I cut some of the slides, so it's redone from Nature, but it's a very good slide. This is the 57, this is the 68, and in both cases, you see what was in the human population in this color, And we added genes from avian source in red. And then we added genes from avian source again in 68. And every time you have a new pandemic virus. This is clear to everyone? Any questions? Yes?
I just have a basic question. The way that influenza is seasonal, and during the time that it's not active, is it plankton?
No, it's not, yeah. That's a very good question. So when we talk about seasonal influenza, we mean in places in the globe that have seasons. So we're talking about the northern and southern hemisphere, but we're not talking about the tropics. So if you go to the tropics, influenza is active all year long, okay? And of course, influenza is more active during the winter, and so in the northern hemisphere is our winter, but the southern hemisphere is going to be different months. Why is it more active during the winter? In part, people are more crowded during the winter. They get close to each other. They get as well other viruses than influenza, which may make things easier to transmit. But in part, it's thought that the lower temperature and humidity increases the droplet transmission of influenza. And so it has to do with the climate, and it has to do with the behavior of people as well. But so there is always influenza in human beings somewhere because you have at least the tropics. And remember, you also have the reservoir from animal sources as well. But the seasonal flu is not, leaving the human population ever. It's not latent anywhere. It keeps on infecting people all year long because of that distribution.
Are the viruses that are eradicable by vaccination, like smallpox and polio, do they not have a reservoir in another species?
Exactly. Yeah, so if you have an animal reservoir, you cannot eradicate it. You could kill all the animals, which people have tried many times, but it's very difficult to eradicate a disease that has an animal reservoir. You could eradicate it sometimes. For example, Chagas disease, good example. You have a huge animal reservoir, but people initially get infected by the bite of the vector, which is a redouvide bug or kissing bug. And if you just change the place where people live, and there's no way for the bugs to reside where people are, they don't feed on people's blood, and you eradicate the infection. But it's an exception, and it still is Trypanosoma cruzi in the animal population, and could be reintroduced if you just stop having good standard housing. But in general, if there was an animal reservoir, we can eradicate it. Yes?
One line of question. Once you recover, the virus goes away, or like sometimes, like herpes could remain dormant in the same person for a long time?
So the virus doesn't become dormant, but it can be shed in the respiratory secretion. So in immunosuppressed patients, as long as a month or more. So definitely in bone marrow transplant, people are very immunosuppressed. It can actually be that you have a persistent infection in the respiratory cells. So that's not really an important reservoir because worldwide that's not the way mass transmission will occur. Kids, though, are a much better reservoir, but it's only for about 10 days, a little more. But, they hug you, they're all over you. And so they're very effective at transmitting the flu to their family members and schools, etc. So the role of schools and the role of kids in transmission of influenza is significant. But there is not a dormant influenza like there was for herpes viridae, for example. Yes, sir.
If it's transmitted better in the cold, then shouldn't it not be active in the tropics?
True, but it is active in the tropics all year. And so in our situation, we behave differently in the summer and in the winter. In the tropics, there is crowding all the time. So the difference is the behavior is quite different in the tropics. So if you go, for example, to sub-Saharan Africa, in the meningitis belt, you see kids sleeping together in the same bed, and their heads are like inches from each other's. And so, of course, it's a transmission that's very different from what we see here. We see here in dorms, when they go to college, sometimes meningitis epidemics can occur. But the transmission is quite different in the tropics because of the lifestyle. many more kids, many more people in limited housing. And so that's part of it. Then the other issue, of course, is also hygiene. You know, if you have no hand washing, you're going to have more transmission. And the humidity also matters, not just the temperature. And so having said all that, there may be also other things we don't know about the seasonal flu, why it's seasonal. So there are still controversies in that. Very good. So those are great questions. I love those. So we talked about already this point is that we have the two different receptors in birds and in mammals, in humans, but pigs have both, and so they are mixing vessel allowing the reassortment of these. So in both epidemics here, when we look at that, it seems like it goes straight to human being from avian genes, but actually you have to think of this as in between you have the pig, okay? And so the pig gets infected by avian flu and gets infected by human flu, and that's why you're going to see more of this occur so in Asia and Hong Kong in these two cases, because you have a lot of people and you have a lot of pigs and they're very close to each other. And so it's not surprising that the pandemic was born there. Not in a negative way. The pig is a fantastic animal and everything can be eaten. It's very important to the culture of people. It's just that it does get the flu. All right, let's talk about the big bad wolf, the Spanish influenza, okay? So that was different. It was not a result of a reassortment. It was really all the genes from avian flu went into the human population. That's what happened here. So that's an avian flu pandemic, right? So quite different. So it was an avian influenza. How do we know? Again, we sequenced the virus from autopsy tissues, and we know that is actually accurate. It happened all together. So what about the big bad wolf? What is it so bad? It infected 1/3 of the world population. It killed 50 to 100 million people. You'll see different estimates, but that's more than World War I, okay? And greater than 600,000 people in the US. Also, when you look at the case fatality rate, which was less than 1 per thousand, 0.1% for the pandemic flu we talked about, here was greater than 2.5%. So a huge mortality rate, okay? And so that's very atypical, and it's very scary in a pandemic like that. So when we say we're afraid of pandemic, we're really afraid of this pandemic. This could kill a lot of more people than then, because the population of the world is much greater now than it was then. So when we talk about 50 to 100 million people, you could extrapolate that to 500 million people now, so that would be something. So it was in the US detected first in prisons and military bases. So we were talking about crowding, and there was crowding because of the war with the troop movements, and that allowed a very rapid spread of the virus. So these are pictures I got actually from the web. They are very nice sites. This is an emergency clinic in Fort Riley in Kansas, so these patients are all admitted with the flu. And it's another emergency hospital in Kansas, but this is in France, same thing, all over the world. So that's scary. Overwhelming everything we have, the hospitals, the drugs, and if we had vaccine at the time, they didn't have neither drugs or no vaccines, but would have also overwhelmed the ability to do that. Looking at the curve of mortality, you had this high mortality in very young and older than 65, but you had a M rather than a U curve, a W rather than a U curve. You had a peak in young, healthy people with no underlying conditions. And you have great descriptions of how quickly some people died with this flu. So it was pretty terrifying too, because people tend to cough up blood, and it was blood sprayed on the walls, for example. So
is that because of military concentrations? And
why this happened? So this is not, the transmission is because of the military concentration, but this is probably, in part, they got a lot of them infected. But also, a lot of them had an immune response to the flu that was more severe. So there were two factors. They had a high attack rate, but they had also a high mortality rate for people who got the flu because of, and we're going to call it a cytokine storm, but how do we really know? We don't have good data about what happened. A lot of people then died from influenza pneumonia as well as bacterial pneumonia. And so both factors were there. You could also say, you know, there was a war and there were a lot of people whose immune system may not have been completely fine because they had endured privation during the war. And so that may also have something to do with the very high mortality. But it's thought that the virus itself had also something to it that made it more deadly.
When people die, I don't know if you want to talk about that later, is there any way to handle the bodies? I mean, let's say that a lot of people are dying, bodies precaution, buried some way.
Well, you had to handle a lot of bodies. So there was definitely, the morgues were full and they had to bury them as quickly as they could and all these things, yes. There is not a risk of infection, not a high risk of infection from the body unless you do, you know, procedures on the body. Because remember, it's mostly the live people who are coughing and sneezing that are going to actually transmit the infection. But there is like an overwhelming situation where you have a lot of bodies to take care of very quickly. So that was definitely a big problem as well. So the causes of death in the Spanish flu was bacterial as well as influenza pneumonia, and then a minority of patients had a systemic reaction, ARDS-like picture, and die also very rapidly. Now, the other thing that's very interesting is the 3 pandemic waves, and that's what scares people a little bit about this pandemic influenza. So the first wave was, this is mortality per 1,000 people, killed about 5 per 1,000. So it was bad, but it was not as bad as the next one that killed 25 per 1,000, and then another one in the winter that killed about 10 to 15 per 1,000. So this triple strike, with the first one not being as bad, is what is very peculiar about Spanish flu. So the first wave mortality was reasonably high, but not overwhelmingly high, was followed by a much higher mortality in the second wave, and then still high in the third wave. So what happened there is that the virus changed between the first and the second wave. It became more adapted to human population and became more lethal. And so that is a scary part about any pandemic. The virus that's in the pandemic can worsen and become more aggressive. So looking again at Spanish flu, it infected human beings from birds and then persisted until the 50s, then went away and was reintroduced from Russia and is still here. And now it's a benign seasonal flu. It actually kills fewer people than H3N2. So we have some genes that show that the virus was probably more aggressive. For example, it has first an avian-like virus with some amino acid from humans. It had no multi-basic hemagglutinin cleavage site, which is a hallmark of severe virus for influenza. And it also had a PB1F2, which on the other hand makes things more severe for humans. But there are a lot of markers that we don't know. Okay, so we don't really know why that virus was a super virus in some ways, which means we also cannot predict what will happen next to the pandemic influenza. And so this is our whole picture. So we saw this and we talked about that. But of course, this slide was before our pandemic influenza. So pandemics, rapid transmission, concurrent outbreak throughout the globe. Influenza disease outside the usual seasonality. So like we see that now, we have cases outside the flu season. High attack rates, high mortality in healthy young adults. We're not seeing that much now. Multiple waves and a variable interval between pandemics that we cannot really predict. So this shows you what happened. You have a pandemic, and then the level of immunity builds up in the population, and the severity of the seasonal influenza goes down. Then you have a new pandemic, and the same thing happens. Avian influenza was scary to us because it had high mortality. So avian influenza started in 97. So first there was an episodic in poultry. In the beginning it was mild, but then it started killing a lot of chickens, and so that was an economic cost. And a few humans got infected, 18 in Hong Kong, always through direct exposure to birds. And human-to-human transmission may have occurred, but it was really not efficient. It was bad for the chicken, and the chicken-to-human transmission was not easy to occur. When it occurred was in that kind of condition. This is a market, live birds, very good risk of transmission in that situation. The human doesn't have a lot of good receptors in the upper airways, but has some in the lower airways. So if you have a very high inoculum, the lower airways can get inoculated, and then you develop severe disease. Okay? And so later, what happened is that there were a disappearance of the avian flu, but then it reoccurs 6 years later with a vengeance, and now it has spread in Asia, Africa, and Europe. So is this a pandemic? No, it's not. Why not? Because the transmission from human to human is not occurring in an efficient way. Okay? So you have that requirement of person-to-person transmission that's not fulfilled. And the latest, I looked at the data from November 27, 444 cases, 262 deaths. Nothing compared to seasonal flu, right? So this is nothing yet. That's what we can say. Will it become bad? That I don't know. So the reason it's nothing is because it has this receptor 2-3 preference. It doesn't have the tropism for the human receptor. It has severity features, though, so when we do get it, we get really sick. And there are not many people who get this and are not symptomatic. Okay, so everybody who gets avian flu gets sick. And the mortality has increased, actually, over time, with the latest cases being 60% mortality. But fortunately, transmission has not improved, and so it's not currently high risk for pandemic, but it can evolve. So high mortality rates is there, most of them in younger people. Rapid progression, highly lethal but uncommon. The problem is that we know there are some features that make it scary as a pandemic, because it's well established in migratory birds in all continents, but especially throughout Asia. It is changing over time. There are at least 10 clades now and multiple subclades. And initial human infection were from clade 3, then they were from clade 1, and now from clade 2, meaning the risk of a pandemic may change as the virus changes. And now let's talk about our swine flu. So there was swine flu before, and you'll hear about swine flu infecting humans. We had swine flu infecting swine, number one, the classical swine, H1N1, and then a triple reassortment H3N2. And there are also cases that infect human beings from time to time. But those are rare things. They are very odd things. And it's an infection from swine to humans. So that's true swine flu. This is classical swine. This is North American avian. This is human. And they got reassorted in the swine into this virus we call triple reassortant swine flu. Okay? But then our swine flu, new pandemic influenza, comes actually from that. So first, cases were seen in Mexico, but we didn't know what it was. And then in California, it was identified as a novel H1N1 influenza, and then found to be related to the outbreak in Mexico. And what was worrisome about swine was that it was mainly in farming, pig farming regions that you saw this flu. And so people thought this is swine flu, and they called it swine flu. But it's not really swine flu. It's a misnomer. It's a human influenza virus, not a swine virus. And we should call it really influenza A H1N1 2009. And if you want to say it's a pandemic one, you should say that. It is different from the seasonal one, as we said. But it is very close to that triple reassortant porcine influenza, and it reassorted once more, and so it's called a quadruple reassortant virus. And so when we look at that here, it's easier to see. So you have the classical swine, the North American birds, human H3N2, they reassorted in a triple reassortant, and then a Eurasian avian swine flu reassorted too in the pig, and this was able to be transmitted to people. And now it's very easy to transmit from person to person. So this is where it's coming from. All right, so let's not call it swine flu. It's a human flu because it's easily transmitted from person to person. Or in other words, all flu somewhere was swine flu, but we don't call them swine flu once they go from person to person easily. Any question on that? Good. And so this tells you the same thing. In other ways, the same thing. So what do we know about it? It had a high attack rate, and a large majority of the population was thought to be susceptible. It was very quick to go across North America within weeks, and then rapidly to other countries. And in June 11, WHO declared a worldwide pandemic, and people say, where are the dead people? And they complain about that. But it was a good thing to do, even though I complained about it too at the time. It was a good thing to do because of the things people did to prevent mortality and increase the production of vaccine, decrease transmission, and these kind of things. One thing that's peculiar is that it infects very few people who are older than 65, and so that's going to decrease the mortality, right? Because most of the mortality was in older patients, in all kinds of influenza. And that's because they have prior immunity from either prior, not the current H1N1 virus, or because of multiple immunizations and with cross immunity over time build up a cross immunity to this virus. And so this is in people who are older than 65. 30% have documented cross-reacting antibody, but those who do not may also have some level of protection. So we're not going to see a lot of cases in them, but if they have influenza, they will get sicker than other people, like all elder patients with influenza do. So it doesn't mean you should not immunize them. This is the latest map from WHO. It shows you a lot of activity. It's actually increasing in Europe. It's decreasing in the US. But you have a lot of activity with this virus. So far, reports, 400 and some cases, 1,000, at least 5,000 deaths. That's not real. That's the numbers they report. But the real number is much greater. So this is a marked on the reporting. Because we don't report patients who are not diagnosed, and a lot of patients get the flu without getting diagnosed. A lot of them don't have severe disease and never go to the doctor, okay? So lots of us probably got already this virus, and we don't, some of us actually keep working even though they should not, but we don't necessarily know that we had it for sure if we don't do the test. Good news so far, it's not changing. It's the same in the latest isolate as it was in the first isolates we got. No rapid evolution has occurred. And so it's not, apparently not adapting to us in a meaner way. It's not going to kill us more in the fall than it did in the summer. It has low mortality rate overall, very low, actually lower than seasonal flu. So that's kind of interesting. But remember, it can change. It definitely can reassort with a virus with different genes that make it more deadly for human beings. You just need two mutations that eliminate the stop codons in the PB1F2 genes, and then we'll have that. And so these things can change quickly. That's one reason to get immunized as well, okay? Because the virus can become more lethal. So we see median age is very early, a lot in little kids, lowest in older patients. Not many over 65 admitted to the hospital. Many kids are, on the other hand. Nosocomial transmission able to prevent infection. you still might get infected, but you'll get less severe disease. So that's what we do every year. Often there are little changes, but the vaccine has some level of efficacy. If it changes a lot in the hemagglutinin or neuraminidase, you'll have no efficacy. But you can acquire other genes that have nothing to do with being protective against the virus, but increase the lethality of the virus if you have no immunity to it. So if you get infected, then you'll die more often. But you're not more likely to get infected because it acquired these new genes. So that's more like that. So this shows you, for now, it is increased mortality with this virus. It's not a completely benign thing. This is your normal seasonal flu, and we have increased mortality already as we are now. And the cases have peaked in the US. It's already coming down, but they may come back like the 3 waves we saw in 1918. And it's still active in most states. These are the high level of activity. You see Illinois is just below now regional activity. But it's coming down, so that's a good news. This shows you the same thing. We can maybe talk quickly about resistance. So drug resistance, pandemic flu is resistant to amantadine, rimantadine, but susceptible to oseltamivir and zanamivir, okay? So true, there is resistance to oseltamivir, but it's less than 1%. That's not surprising. We see that easily. The H3N2, which is the other bad flu we have, is, on the other hand, susceptible to oseltamivir and zanamivir and resistant to amantadine, rimantadine. And the H1N1 that was wimpier, if you want, already, is actually often resistant to oseltamivir. What does it tell me? If you have someone who comes with the flu and you want to treat, you don't want to treat everyone, but if you want to treat someone, oseltamivir is a fine therapy. Because the only one that we may not cover is the one that's much less significant right now and was already less lethal before this pandemic flu occurred. Okay, so you can still be comfortable using oseltamivir. The IV form is no better than oseltamivir. It's just if you can absorb the PO, you could use the IV peramivir. Diagnosis, you should not wait for diagnosis to treat, but diagnosis with the usual RIDTS doesn't work. You need reverse transcriptase PCR, and that takes sometimes longer depending where you are. And so don't wait for confirmation to treat these patients. And so we'll skip that. And so in summary, there is no reason to panic about this pandemic because it has low mortality. But there are still some unknowns. It could change. And so there is also good reason to immunize people. Good reason, even if it didn't change, because even though it doesn't kill a lot of people, it kills 3 times more children than the seasonal flu, okay? And it killed 10% of people who died were pregnant women. And so it has differences from seasonal flu that kill people who otherwise would have lived for many years. Well, remember, the seasonal flu kills a lot of people who may not have lived for many years because they were older or sicker. So that's one reason that this should be an aggressive season for immunization. The second reason is that it may come back as a second wave that will have acquired new genes that makes it more lethal, and then it'll be too late. And so we have to do that now. We're lucky it's not a severe pandemic, but we should do that very aggressively so that we prevent much more mortality later. But the other thing I told you, and that's why I talked about the avian flu, is that that's another threat for a pandemic that's still there. Because the press doesn't talk about avian flu, doesn't mean we shouldn't talk about it anymore. It's still there. And so we still have to watch influenza. We always have to watch influenza because of that potentiality for very severe outbreak. But however, it's unlikely we'll have as bad an outbreak as in 1918 because that was a perfect storm. There was a war, there was a very aggressive virus, there was no antibiotic, there was no vaccine, and they didn't know even it was the flu until late in the pandemic. Thank you very much. Yes?
Two questions. One, does reassortment of any sort occur in humans, particularly if they're co-infected? And is that a means by which resistance to antivirals and other significant mutations occur? And then second, is there some magic number, I forget from epidemiology, for achieving herd immunity in terms of proportion of the population vaccinated?
So the first question, is there a reassortment of influenza in humans? Yes. Is it important in terms of epidemiology? No. But it is kind of interesting to know that. The same thing occurs with HIV, by the way. So it's kind of a very interesting aspect of this. It's not important in terms of epidemiology because it's much more likely to happen in swine. And proportionally, it's much more important. The second question, there is no magic number because it depends a little bit on the efficacy of the vaccine. So some years the vaccine is going to be better than others. These vaccines appear very effective, and so we may not need as many people to be immunized, but you typically look for 80% immunizations to have a major effect. Although you may have effects before that. Remember, people who get the flu and got immunized don't get admitted to the hospital, they don't die, and so there is much more also of an effect that way, that you don't keep on transmitting in hospitals. Yes?
Two questions. You showed in the map that in Africa there was not too much,
right.
And I don't know if it's not reported that
yes.
happened. And the other one, what do you do or how do you encourage people for vaccination? With my patients, 50 or 60% for this, they refuse. There is no
right.
way that you can. So what do you, because you talk about behavior,
yeah.
How do you address it when people?
That's a great question. So that's something we deal with every day. So I deal with HIV patients a lot, and they say, no, I don't want it. It's swine flu. First thing you tell them, it's not the swine flu. It's human flu. Forget the swine. That's not a good name, okay? And the second thing you say, it's the same vaccine as you get every year.
No, they refuse that.
If they refuse every year, they're going to refuse this one. But you have people who take the seasonal flu but refuse this one. Those can be convinced by telling them it is the same vaccine you get every year. Every year we look at the latest virus, but this virus came too late to be in the regular vaccine. And so it comes as a different vaccine. Next year it'll be in the regular vaccine. Many people don't want the flu shot. Why? You ask them why. So the problem is much easier to say fine, But if you talk to them, you can convince about half of them who said no initially to take it. There was half of, including nurses, including doctors, okay, who do not take the flu shot. My father always said, I never get the flu. I never get sick. And then he got a Hong Kong flu and almost died from it. I remember, so I was a kid, but I remember how he was coughing pink stuff and horribly sick. And guess what? Didn't get the flu shot after that either. And in the end, got it only in his older and wiser age. And so, yeah, it's true. It's very difficult. There is an issue with the flu shot, which is the preservative they use in the multi-dose vaccine. So this is no longer in the other vaccines. So there are some people who think this can cause autism. All the studies show it doesn't. But it doesn't matter to people because they don't believe in studies anyway. And so if they say, no, I don't want my kid to have autism, what you can do is tell them if you use a single dose vaccine, it doesn't have, it has very, very little, which all vaccines have very, very little. But it doesn't have the amount that you have in the multi-dose vaccine. So using a single dose vaccine, explaining to them, saying that there was no evidence at all, since they stopped putting this preservative in all the other childhood vaccines, there's not been a decrease in autism at all. So all those are things you can say, but guess what? It's tough because there are a lot of other people who say it's a horrible vaccine. It's a good question too because all vaccines we should be clear about advocating them, and so we need to know them, know the adverse effects. You have every time you go on the web, you get the VIS from the CDC. You can give them that sheet, so you inform them. They feel that you're telling them the whole thing. Not just the positive, but then tell them about the positive of the vaccine. So little by little, we can convince more people. that patient may not be convinced, but the next person may be, and then be an advocate as well.
Are you aware of any effort by the WHO to make vaccination available for, like you showed there's really no data from sub-Saharan Africa.
Yeah,
If it gets in there, it's going to be terrible.
So WHO is interested in doing that. Whether it's going to cover the whole globe, I don't think so. And so, you know, I know this is a conference on ethics as well, but think about the ethics of getting this vaccine in the US first if it was a very deadly pandemic we were dealing with and we didn't have the vaccine yet. And now think about the ethics of that on a global way. When you think all the people who are in the developing world and don't have access to the vaccine or will have access to the vaccine late. So things have to change in terms of we have to produce this vaccine quicker in the future by using cell cultures. And the governments, including WHO funded, have to put more money into having flu vaccine ready every year in more countries. Yes?
I haven't reviewed the literature about this now, but they used to say that people who had Asian flus get Parkinson's, and they used to say in about 30 years nobody's going to have Parkinson anymore. Or those who had Hong Kong flu, they used to say have a ependymal tumor in the brain. Is this still valid from what you know?
I haven't seen that. I know the von Economo encephalitis, which was with the Spanish flu, was associated with severe Parkinson, and there was this movie called Awakenings, which is a great movie which talks about that. We're not 100% sure it was due to the flu, but there was definitely a possibility of that. And so it may have caused in a subset of people a encephalitis that was different from the typical flu encephalitis. Now, flu can always cause encephalitis and cause sequelae, so there was just something more aggressive maybe about this virus. So if someone had an encephalitis from flu, they could have Parkinson's from that. But the peculiarity was in 1918 and after. Yes?
Can human flu cause pandemics in birds?
So human flu is not adapted to the bird receptor, and so no, but we can infect swine, we can infect our dog, and so we can actually, through the swine, then participate into outbreaks in birds because it goes back and forth. But remember, birds are not all the same. Many birds are asymptomatic. Wild birds that, like ducks and geese, do not get sick from the flu. They just carry it and transmit it. But domestic poultry get sick from some forms of flu, and then you lose all your chickens in 3 days. And so it's very different, a disease in domesticated birds. And so it can go both ways, but usually through the swine. Yes?
I don't know if it's ethical or political, but when it started in Mexico, they say there was a big issue about the poor conditions of the workers working in the factories with the animals, that they knew a long way before it happened, and there was not enough hygiene, and so ethical, political, it seems that there was enough information for this when was going on and nothing was done. Do you know anything about it?
I think it's true. So there was delayed because it was in Mexico in February, and we really didn't do anything for 2 months, and there were lots of people dying. Yeah, and it may have been there before, we just didn't know. But it was known from February something was going on. And so I think also mortality was much greater because there was no good access to care. And then, hygiene. So surely if people have the flu and keep on working, everybody else is going to get the flu. And so this aspect definitely is important.
I mean, most transmission is still going to be person to person, even in that situation.
Yeah.
Yes.
Yeah, but it was, people felt totally like victimized. You talk about washing hands, and in a lot of places there is no water, right?
Yeah. Yeah, many places of work, you have to go to work even if you're sick or you lose your job, so these kind of things. Yeah. There was one more question.
People with swine flu, should they get the vaccine?
Yes, unless they know for sure, and nobody knows for sure. So yes, the answer is forget about it. Forget that you had something you think was the swine flu, unless you had the right test. documented positive and you have a printout of it, take the flu shot. It won't hurt you, and it's very safe, and you don't know for sure if you got that flu.
Thanks for coming.